Welcome to EADV Live. Today's topic, Vulva Dermatology. I'm Christopher Horskamp, and on behalf of the EADV, we welcome you to today's interactive webcast. If you have any questions or comments about the subject matter, send them in at any time during the presentation, and our presenter will do her best to address them at the end. Today, we are joined by Dr. Fiona Lewis. Dr. Lewis is a consultant dermatologist at St. John's Institute of Dermatology at Guy's and St. Thomas's Hospital in London, England, where she leads the vulval service. And with this, I hand it over to Dr. Lewis.
Great. Well, I hope you can all hear me and see the slides. So thank you very much for asking me to talk today. So vulval dermatology is a very interesting part of dermatology, but I think people often find it difficult. And hopefully by the end of today, you can have a better idea about how to diagnose and manage some of the common things. And I have no conflicts of interest. So why do we bother with vulval dermatology as a separate subspecialty? So there are some very important specific dermatoses that affect the vulva, and any dermatologist should be able to manage these at a basic level. And you will also see patients who have very generalized skin disease, like psoriasis, that's the classic example, where you may need to manage the vulva as part of generalized skin disease. And as I will show you, the management in the genital area is not always the same as it is elsewhere. And you may be asked for an opinion from other specialties, particularly like gynecologists, pediatricians, urologists may ask you. And it's important to be able to help from a good dermatological standpoint. And importantly, there are consequences of getting it wrong. I just show you here a patient with erosive lichen planus who had very severe introital stenosis with problems passing urine. And this patient had had several operations to remove that, but nobody had recognized the underlying diagnosis. And also, it's important to avoid unnecessary treatment, because with anything, you need to know what is normal. And if you know the normal structures, the normal anatomy of the vulva, then you can often reassure the patients that this is a normal part of anatomy and that no surgery or excision is necessary. So if we look at vulval dermatosis, this is a very big topic, and we can't possibly cover this completely in 40 minutes. But if we first of all look at the symptoms, so I would guess probably most patients will present with itch, but some will present with soreness and some with pain. And certainly if a patient ever complains and uses the word irritation, it's always really important to just ask them, do they feel that they want to scratch the skin? Because often when a patient uses the term irritation, we think that they mean pruritus, they mean itch, but that's not always the case. And it's always helpful to qualify that at the time. And then there are all these different topics that come into vulval dermatoses, vulval dermatology. And we can't possibly cover all of these today. So what I'm going to do to structure this talk is to talk about things, the common things that we see. So eczema, psoriasis as it affects the genital skin, and then the two very specific dermatoses that we see, lichen sclerosis and lichen planus. Because this probably covers most of the things that you will see. The other things like vulval pain, precancerous lesions like VIN, etc., we will just not have time to do. So let's start with eczema. Now, as you know, there are many different types of eczema. And again, the vulva is slightly different in the distribution of eczema that affects it. So atopic eczema actually very rarely affects the vulva. it actually sometimes spares the genital skin. So you'll often see children with very severe atopic eczema, but actually the napkin area is not affected and really not a problem. So the endogenous eczema that mainly affects the vulva is seborrheic eczema. Irritant eczema is by far the commonest type of dermatitis eczema that affects the vulva, and then allergic contact dermatitis is much less common. So if we look at seborrheic eczema, one of the big things here is that you will see that this is always mistaken for thrush. There is definitely inflammation here, but in the interlabial sulci, you will see lots of keratin that just builds up, and it looks like the discharge of thrush, but is nothing to do with it. And often if you ask the patient, they will have scaling of the scalp and evidence of seborrheic eczema at other sites. And then thinking about contact reactions, so exogenous eczemas. So an irritant contact dermatitis on the vulva is very common, particularly in the young and in the very elderly. So older women who have urinary incontinence will have significant problems with irritant dermatitis, as will young children. Allergic contact dermatitis as a primary problem affecting the vulva is actually rare. We do occasionally see it in combination with different topical treatments. Patient may develop an allergy to one of the components, but as a primary problem, it's uncommon. And then contact urticaria is extremely rare. When I say contact urticaria, I'm talking really about latex allergy and semen allergy, both of which are really much less common. And the diagnosis there is very obvious, because if it's a latex allergy, then the problem will be completely abolished if a non-latex condom is used. So with an irritant dermatitis, as I was saying, this is very common. Anogenital skin is much more susceptible to irritants, and things like moisture, friction, and a vaginal discharge can all contribute to irritating the skin. And when a patient has a problem, what often happens is they then start to wash many times during the day with lots of different chemicals, lots of different preparations, which again will just aggravate the problem. And urinary incontinence is a big issue, and certainly in elderly patients that present with a skin problem, it's really important to refer them so that the urinary problems are addressed. Otherwise, the skin will be very difficult to control. So irritant eczema often extends into the perianal skin. It's often symmetrical, and sometimes it will have a very scaly rim. So this is an elderly patient with significant urinary incontinence, and you can see this very ill-defined erythema, which is on the sites that are most in contact. So it's always on the convex surface, and in children you will often see that on the buttocks as well. It's the area that's most in contact with the primary irritant. Whereas an allergic contact dermatitis tends to spare the folds. This sometimes happens with an irritant contact problem, but you can see here quite easily that the main area is actually on the sites that will be in direct contact with the topical treatment. This is a patient who was allergic to neomycin. And if we think about allergic contact dermatitis, there are common groups of allergens that will frequently cause vulval allergic contact dermatitis. Some of the local anesthetics, particularly the cane esters, such as benzocaine, which is in several over-the-counter preparations, can frequently cause allergy. Preservatives in different emollients and in treatments, antibiotics, neomycin being the main one, fragrances, and then it's possible to actually be allergic to topical steroids themselves, actually to the steroid molecule. And the other thing, moving away from topical treatment, is clothing. And that always needs to be remembered, because the azo dyes in textiles, again, will cause an allergic contact dermatitis. And there are several others, but obviously much less common. You'll all be familiar with patch testing. That's how we work this out. But if you suspect that a patient has an allergic contact eczema, then you need to do much more extended patch testing, not just to, I've put here the BCDG standard series, that's our British Contact Dermatitis group standard series, but you need to do preservatives, you need to do a special vulval perianal series, and also textiles, so that you'll pick up the dye allergies as well. So in managing any eczema, the first thing is to avoid the cause. So if you found a relevant allergen on patch testing, that needs to be avoided. Again, if there is a problem with irritation from urine or other treatments, then that needs to be addressed. So firstly, we would use very bland ointment-based emollients as a soap substitute. Just the old-fashioned BP formulation emulsifying ointment is very helpful. That can be used as a soap substitute, but also applied to the skin. And then a topical steroid, usually a sort of mild to moderately potent, would be quite adequate. And again, thinking about the potential problems with urinary incontinence, then a very good barrier preparation is very helpful. And this is where people often will get confused with the term lichen, because lichen basically means thickened, and there are lots of different skin problems that incorporate that term lichen. Now, lichen simplex is related to a chronic eczema, just as you see that on the skin elsewhere, often on the legs or the back of the scalp. The genital area is quite a common area to be involved. And you will see the history is always that these patients are very itchy. They will wake up at night scratching. It may well have started as a mild eczema, but then what happens is the skin starts to thicken. And just to show you the important differential here, if you look at the inner vulva, people will often mistake this for the palette of lichen sclerosis. The architecture of this vulva is totally normal. And this skin is slightly pale, but it's pale because it's thickened and not because it's sclerotic. And it's an important marker of the differential diagnosis of lichen simplex and lichen sclerosis. It can sometimes be unilateral. So you'll see here, this is a patient who's right-handed that really has only been scratching the left side of the vulva. It's more common for it to be bilateral. And perianal lichen simplex is very common indeed. And certainly often patients that develop vulval disease to start with, it will often start to then involve the perianal skin as well. So the management of lichen simplex, again, is very similar to eczema. Emollients as good moisturizers. You need a more potent topical steroid. You don't need an ultra potent, but a potent strength. And it needs to, these patients need to be treated on a reducing regimen. So the itching and the symptoms will often get better very quickly, but the thickening, the inflammatory component takes a lot longer. And so we would normally use a potent steroid once daily for a month, alternate days for the second month, twice weekly for the third month, and then just as needed. Antihistamines might be helpful initially until things start to improve, but don't need to be used long term. And it is worth thinking about patch testing patients if there is significant perianal disease or there is no response to treatment. But in general, these patients respond extremely well to 3 months of treatment and don't need any further investigation. So then moving on to psoriasis. This is a very common problem, but psoriasis looks very different on the genital skin. You don't have the scale that you would see elsewhere because of the environment being very moist. But what you do see is this very well-defined erythema that you can draw a line around, which is quite different to the pictures of eczema that I just showed you. And Perianal involvement is again very common, so it's very helpful to look at that area and examine that as well. Again, you will often see very well-defined areas and this is often very itchy. Fissuring is very common with psoriasis, and gluteal cleft, natal cleft involvement is almost diagnostic of psoriasis. You do sometimes see it with eczema, but it's much more common with psoriasis. And there's recently been a very helpful study from French colleagues looking at genital psoriasis. This study does include men as well as women. And one of the things that I've always thought is that vulval psoriasis is never as easy to treat often as it is elsewhere. And this study really confirms that. We know that about 40% of patients with psoriasis will have genital involvement. But dermatologists, we're not very good at asking about genital involvement when we see patients with generalized disease. And the patient probably won't tell you they have genital involvement unless you specifically ask them. And it is important to examine the area as well. But interestingly, over 20% who had very good control of their psoriasis on a systemic agent like methotrexate or even biologics continued to have genital lesions. And certainly I have several patients whose psoriasis outside the vulva is completely clear, but the genital disease often requires ongoing treatment. And I have to say, I think topical treatment is by far the most effective. There is now some evidence that ixekizumab may be helpful for genital psoriasis, and so that may be something that will be helpful in the future. But as far as management with topical treatment is concerned, again, using a moisturizer as a soap substitute and on a daily basis is helpful. And a moderately potent topical steroid, again, weaning down the potency so that you come to the least treatment required to keep things well controlled. So I'm going to spend the next half of the talk on the two conditions that are very specific to the vulva. Lichen planus often has elements of disease at other sites, but lichen sclerosis is by far the commonest skin problem that we see affecting the vulval area. So this was first described by Henry Halepo in the late 1880s. So it's well over probably about 150 years since this was first described. And just one of the things to point out is that there is a lot of confusion about terminology, and all of these terms have been used to describe lichen sclerosis, but specifically the et atrophicus terminology really should be dropped, and the condition should be called lichen sclerosis, so not LS et A. In men, the term balanitis erotica obliterans is still used sometimes, but the disease is lichen sclerosis, and the International Society for the Study of Vulval Disease used that term in the 1970s, and this is really what we should be calling the disease today, because it is not always an atrophic disease, and actually recognizing the pattern of disease that is not atrophic is very important, because those are the patients that may well have an increased risk of malignant change. So what causes it? We still don't really know. It's thought that there may be genetic factors, and this is supported by some work on HLA antigens. But interestingly, although these have been DQ and DR HLA antigens have been linked to lichen sclerosis in women, there is much less evidence for this in men with lichen sclerosis. Is it an autoimmune disease? Well, it has links certainly with other autoimmune conditions, and antibodies to the basement membrane zone and to extracellular matrix protein have been shown, but there's a lot about lichen sclerosis, particularly in men, that doesn't have the flavour of an autoimmune problem. And then infection, there was a vogue for thinking about Borrelia, but that really there's little evidence for that in big studies, and certainly no evidence for HPV infection either. We know that the skin immune system is involved at all stages, and that even in treated disease, you can have increased cytokine activity and HLA-DR expression. But the ultimate cause is not known. There may be epigenetic factors as well, which is an emerging theory. So if we look at some clinical examples, this is extragenital lichen sclerosis, and this occurs in about 10 to 15% of women with genital disease. And certainly as dermatologists, you will sometimes see patients that present with a white area on the trunk, often at sites of friction. And if you ask, they may not have any genital symptoms, but if you look, you will nearly always find lichen sclerosis in the vulva, even though that may be asymptomatic and very subtle and mild. Who gets it? There are two peaks of incidence. There's a peak in the prepubertal age range, usually between the ages of 3 and 5. But the big group, this is a study of about hundreds or so of our patients, the big group is postmenopause. So the vast majority of women usually start symptoms in the 50s and 60s. Unfortunately, the diagnosis is often not made till a lot later, but the incidence into the 70s and 80s of onset of symptoms is actually much less common. And the histology is very typical. You have a very thinned epidermis. Then you have this very dense band of homogenized collagen, which gives the disease its very whitish appearance. And then this lymphocytic infiltration underneath. And as the disease progresses, what happens is that in very early lichen sclerosis, this infiltrate will be much higher in the dermis, and it just gets pushed down as the disease progresses without treatment. So what are the symptoms? So itch is by far the most common symptom. It can be uncomfortable, particularly if you get small fissures in the skin. And dyspareunia, again, related to fissuring, and sometimes the narrowing of the introitus that will occur it can be a problem. One of the big issues in children is constipation, and over 60% in some studies will present with constipation. Particularly if they get perianal disease. That's not so common in adults. So what are the features? And it really is important if you're going to make a diagnosis of lichen sclerosis, you need to have, certainly I would say probably at least 2 of these features present, because we are seeing a lot of patients being told they've got lichen sclerosis with very little evidence for it. So the classic feature is the very white plaque. Ecchymosis, those tiny little bleeding points, are very common. And as the disease progresses, it will lead to anatomical alteration and what we call architectural change, which can be prevented with early recognition and treatment, and fissuring again with active disease. So here in a child, you see this very symmetrical pallor, but with normal architecture. Again, as you see, very symmetrical white plaques, but this patient is beginning to lose some architecture. So the labia minora are slightly stuck to the labia majora, and there is some tethering, some sticking down of the clitoral hood. Again, this symmetrical change, and what you will sometimes see if patients have been scratching significantly is you will see areas of excoriation like this. But if you see that, that must disappear within about 2 weeks of adequate topical steroid treatment. And if it doesn't, then any atypical area like that must be biopsied. This is the classic in all the textbooks, figure of 8, so where it extends perianally as well. Again, you've now got complete sealing of the clitoral hood, loss of the labia minora, although there's some areas here, and again, this white sclerotic change. Again, architectural alteration, but this shows very nicely this marked ecchymosis. And that's not due to the use of topical steroids. That is part of the disease because it's due to the unsupported blood vessels in the dermis, and they pop very easily, and then you get those small areas of bruising. Now, one of the important things to differentiate really between lichen sclerosis and lichen planus, lichen sclerosis never affects the vagina except in this very rare situation where you have a prolapse, the vaginal mucosa becomes keratinized, and you will sometimes develop lichen sclerosis on the area, but otherwise it does not affect the vagina. And as I was saying, beware of overdiagnosis. Know what is normal anatomy. Sometimes the labia minora are just small, but you can't make a diagnosis if a patient just has a little bit of itch and just normal but small labia minora. They need to have those white plaques, fissures, ecchymosis, and we don't want them to get architectural change, but if you see them late without treatment, you will see that. But the major differential diagnosis is vitiligo, and as I've shown you, hyperkeratosis can sometimes look pale. But certainly in the British Association of Dermatology guidelines, we would always recommend that young women are biopsied to confirm the diagnosis, and any patient who has atypical disease, if you're not clear about diagnosing it clinically. So how do we manage a patient with lichen sclerosis? So this is what you don't do. These are all treatments in the literature. I just want to pick out 2 at the bottom here. Topical testosterone, there is no role for testosterone in the management of lichen sclerosis. There is very good evidence that that does not work and gives people side effects. And vulvectomy should never be done without a diagnosis of vulval squamous cell carcinoma. So for benign disease, surgery in women should not be undertaken unless there is malignancy or very severe scarring. Because all that happens is that the lichen sclerosis carbonizes in the scar tissue and causes just as many symptoms as before. So how do we treat it? And there is overwhelming evidence for the use of an ultra-potent topical steroid as first-line management for lichen sclerosis. There are Cochrane reviews, there are grade approved guidelines that all point to that. There are also randomized controlled trials now about the use of an ultra-potent topical steroid. These are the BAD guidelines. There are also some European guidelines which are fairly similar, but older than these. Don't worry about this. You can see all of the guidelines. They're widely available, open access on the BAD website. But this is just the algorithm for managing. And I'm going to highlight this area here, which I've mentioned already, making a diagnosis. So you need to have symptoms and clinical signs. And if you're confident of the clinical diagnosis and you're experienced in managing lichen sclerosis, then it is reasonable to start an ultra-potent topical steroid. But if you are not confident, don't treat it empirically. If you're going to refer the patient, what you can do is to just use a mild topical steroid, because that will help the symptoms to a degree, but it will not alter what we see when we see the patient, because not only does an ultra-potent steroid help the symptoms, it will also reduce and sometimes reverse the histological features. So even a biopsy is not going to be helpful. Dermavate ointment or clobetasol propionate. Dermavate is used in most countries. This is what we use. We use about half a fingertip unit, a small frozen pea size. And an induction regime would be once daily for a month, alternate days for the second month, twice a week for the third month. And then the treatment has to be individualized to maintain control. So some patients might need it once a week. Some patients need very little, and you follow them up and they've not used treatment, but their disease is not progressing. But if you are going to say just use it when needed, then they need to be followed up so that they get the best advice and the things are monitored. So what are the complications? So autoimmune disease is not really a complication, but it's more of an association. But in women, there's about a 40% link with other autoimmune disease, like thyroid disease in particular. Scarring is a problem. You can't reverse that with medical treatment, but you can stop it when you start adequate management. And if a patient does have severe scarring, this applies to lichen planus as well, then certainly that would be an indication to refer to a specialized center, because the surgery for that is specialized, and it does need to be done with very good and adequate follow-up protocols for using topical steroids fairly immediately after surgery. Differentiated VIN and squamous cell carcinoma, SCC, is said to occur in about 3 to 4%. But it does tend to occur on a very specific atypical type of lichen sclerosis. And patients who have well-managed disease do not seem to have that problem. And vulvodynia, there are patients who can develop neuropathic pain even when the lichen sclerosis is treated. So this is a patient with LS and vitiligo. So you'll sometimes see those two diseases together, particularly in children. Differentiated VIN, this is a subtle histological diagnosis where all of the change is going on just at the basement membrane with some mitoses. It's very important to recognize that, because this has a very high risk of developing SCC. And the changes can be subtle, but you see this is a patient with rather atypical LS. There's some odd eroded areas, there's thickened areas here and here. That showed, that's the type of picture that you need to think about differentiated VIN. The risk of malignancy, if you look at it the other way round and you take patients with vulval SCC, a significant number of them will have lichen sclerosis adjacent to that may not have been recognized. And it isn't subtle. This is a patient with treated disease, but again, sudden onset of this painful nodule that was an invasive SCC. So follow-up for patients at 3 months after the induction regime, then 6 months after that, and then 12 months. And if well controlled, patients can be discharged with very good information. But any patient who requires ongoing treatment, atypical disease, or certainly if there's a history of VIN, needs long-term follow-up in a specialized clinic. And so then lastly, just to talk about lichen planus, because this has common features, you'll all recognize that very easily. This is typical lichen planus on the wrists and in the mouth. Again, etiology is not really known. There may be a little bit more evidence for an autoimmune background to lichen planus, because it is sometimes linked to hepatitis C infections and other potential antibody reactions, but again, not clear. Now, in lichen planus, it's a little bit more common in women than men, but this is incredibly rare in childhood. And it really is much more a postmenopausal disease. I have a handful of patients with lichen planus in the reproductive years. It's really not common. And there are 3 main types. So there's the classic type that looks very much like what you would expect to see on the wrists or the skin. The big important one is erosive lichen planus on the vulva, and this particular variant of that, which has a genetic link of the vulvovaginal gingival syndrome, and then hypertrophic LP, which is much less common but important because of the increased risk of malignancy with that type. So lichen planus can be asymptomatic, but it generally presents with soreness and discomfort, burning, pain with intercourse, and often a discharge, because this can affect the vagina. The erosive type can, the hypertrophic and the classic type do not. The histology is different, but again, you have this sort of sawtoothed epidermis, hypergranulosis, basal cell changes, and then this very dense lymphocytic infiltrate in the dermis. And again, this is classic type lichen planus, but this is exactly what you would see on the buccal mucosa, this sort of network of Wickham striae. And again, you can see it here. And if you have a patient with this and you want to biopsy to make the diagnosis, take the biopsy across that edge of one of those striae, because that will give you the most likely and helpful information. Hypertrophic lichen planus, again, these sort of rather odd plaques, much less common variety, very itchy, often presents perianally. And this is the type that may well have an increased risk of squamous cell carcinoma, so it needs to be managed properly. An erosive LP, this is important because this is the one not to miss. So you can see here that this patient has symmetrical erosion. There is loss of the labia minora completely. So these patients get just as much, if not more, scarring than patients with lichen sclerosis. And the important thing with this is the vulval, vaginal, gingival syndrome. You will see that you've got these marked erosions, and if they occur on the walls of the vagina, there's a very strong likelihood that those walls will stick together, and these patients will often present with a completely stenotic vagina, and often nobody can get a speculum in to do a smear test, and that's how they present. There are a couple of other diseases that will cause similar scarring: mucous membrane pemphigoid, graft versus host disease, and the other thing that can be a differential diagnosis with erosive lichen planus is this rather erosive type of VIN. But you can see that in contrast to the lichen planus, this is very asymmetrical, even though it does look eroded, and this is occurring on a background of lichen sclerosis. Now, one of the great things as dermatologists is that you have lots of other areas that you can look at that will give you clues. And the classic and hypertrophic types of LP are often linked with scalp involvement. This is obviously frontal fibrosing alopecia. You can get more generalized scarring alopecia, or even just patches of it. And then this nail changes as well. Again, oral disease, so lichen planus on the tongue, gingival disease, but also lichen planus on the lips is, I think, a lot more common than we think. And never forget perianal skin, because again, you can get perianal lichen planus, which can sometimes cause anal thickening and stenosis of the anal canal. But when we're thinking about erosive lichen planus, there are some other very important sites. We've talked about the vagina, but the gums, but also there are other important areas. So first of all, lacrimal, this is the mouth. Lacrimal ducts, you will see this scarring around the lacrimal duct, and these patients will present with a lot of their eyes water a lot, and you need to be working with an ophthalmologist that understands about this condition, because they can help to manage that. And esophageal lichen planus, again, can be a problem. Patients will present with dysphagia, and these patients will have, you see how it's very friable erosive change, and there is a much higher risk of esophageal malignancy with this type. So as dermatologists, we won't manage that, but it's important to think about it and to refer the patient on. And also conductive deafness, because it can affect the external auditory meatus. So the management of lichen planus, emollients are used just as for lichen sclerosis. The topical steroid regime is exactly the same. Barrier preparations for erosive disease. There is some evidence for calcineurin inhibitors. They're certainly helpful in the mouth, but are not so helpful on the vulva, because they often sting quite a lot when they're applied. And there's no evidence for any systemic agent in lichen planus. People have tried methotrexate, cyclosporin, a couple of case reports about biologics, but there are also a lot of patients reported who have developed lichen planus as a consequence of a biologic treatment. So we don't really know. So topical treatment is by far the most effective. Complications, really exactly the same as with lichen sclerosis. As I was saying, squamous cell carcinoma mainly with the hypertrophic form of lichen planus. So again, this is a patient with LP, but there is the squamous cell carcinoma, this sort of nodular, ulcerated area. But again, you will see very atypical disease the whole way around that. So when to refer on? I think any patient with erosive LP does need to be managed in a specialised clinic, because you need a multidisciplinary team to help you manage the other complications. Any patient with atypical disease, and certainly patients where there's any complication with differentiated VIN, need to be followed carefully. And patients who don't respond to treatment, because there's usually a reason why they don't respond to treatment. That may be because they have developed a complication, or they're not applying the treatment correctly, or there may be another diagnosis. So in summary, I hope I've shown you the clinical features of common vulval dermatoses, the basic management, and when to refer on for specialist management. So that's a picture of St Thomas's Hospital, one of the hospitals I work at in London, opposite the Houses of Parliament. It's where Boris Johnson, our Prime Minister, was treated for his COVID infection. And so I'm going to stop there, and if there are any questions, then hopefully I'll try and answer them for you. Okay, so if I'll just go through, there's a few questions that have come in. So how about cryotherapy for lichen sclerosis? Well, there are a couple of papers about it, but we would never use that. There's never really any reason to use it, because cryotherapy won't alter the inflammatory component of it. I know sometimes people have used it for hypertrophic lesions, but you have to be very careful when you see patients with hypertrophic lesions, because you really need to know that there isn't any start of differentiated VIN, and so those certainly should be biopsied. I have never used cryo for LS, and I think the evidence for it is limited. Now then, do you treat with calcineurin inhibitors? I have to say, hardly ever. Yes, I know there are studies that show that calcineurin inhibitors can be helpful. There's also a very good randomized control trial that shows that ultra-potent topical steroids are far superior to calcineurin inhibitors. And I guess our concern with using them is the potential for aggravating the risk of malignancy. So certainly when they were black boxed in the USA, that was done on the basis of some genital cancers that had occurred. I think one of the problems is that sometimes calcineurin inhibitors are used when topical steroids are thought not to have worked. And again, I haven't had time to go into it, but if a patient doesn't respond to treatment, you need to find out why. And so often that is the problem that is used. They're often used when there may be a complication like differentiated VIN. So I'm afraid I would definitely go for the topical steroids. Used appropriately, they are absolutely fine. What are the different forms of steroids that can be used for oral LP? So, yeah, oral LP is somewhat more difficult to treat than genital, more difficult to treat, but the preparations are more difficult to keep in the area. So the first thing that you can do is you can use a steroid that is dissolved, so a soluble betamethasone. You dissolve that in a glass of water and you get the patient to use it like a mouthwash. And then you can, so they don't swallow it, they spit it out. And they can do that a couple of times a day. My oral medicine colleagues use things like Flixinase nasal capsule. So sometimes things that are used inside the nose, it comes in a gel capsule that can be used inside the mouth. Sometimes you can get the pharmacy to make up a steroid that is mixed with a paste that will sometimes stay on the gum margins. So that's another option. And the other thing that we sometimes use, obviously off license, is that we actually sometimes use a steroid inhaler that you can spray. You often have to turn it upside down and you can spray that onto the buccal mucosa or onto the gingival margins. And that is sometimes helpful as well for oral LP. I think calcineurin inhibitors you can use in the mouth. You can also use clobetasol propionate ointment directly into the mouth, and I know my oral medicine colleagues will do that. It is quite safe to. There's nothing in the ointment that you can't, but it doesn't stay on the gingiva that well. So when you look at the histology of lichen sclerosis, do you think it can be a variant of lichen planus where the infiltrators move down? Okay, so one of the most important things with, I guess, not just with vulval disease, is that you need to have a really good pathologist, a dermatopathologist that you can discuss things with. Because yes, when you have very early lichen sclerosis, that can be very difficult to differentiate from lichen planus, because often the infiltrate is much higher in the dermis than it would be as when you get more established disease. There are some other subtle features that a good dermatopathologist will pick up, like sometimes you can get very subtle thickening of the basement membrane that you see in LS, but you wouldn't necessarily see in LP. So there has to be very good clinico-pathological correlation, because I think if you have a patient where it looks very typical of lichen sclerosis as opposed to lichen planus, and you may see a higher infiltrate, then and sometimes you have to rebiopsy patients, because occasionally there is a bit of an overlap of lichen sclerosis and lichen planus, and so that sometimes is an issue as well. So what do you do for treatment of fissure in LS? Right. Well, if the fissure is very superficial and it's part of the inflammation, that will completely resolve with the application of a topical steroid for a few days. Sometimes it might be helpful to switch to a steroid with a combination of an antibacterial or an anti-candidal, because once you've got a fissure, you've broken the barrier, and then you will sometimes not get infection that you need antibiotics to treat, but you will get increased bacteria on the skin. And so sometimes using a combination treatment for a short period is helpful. And you have to tell the patient that it's absolutely fine to apply the steroid directly to the fissure, because often it will say do not use on broken skin. And so they'll be too worried to apply it, but that usually is fine. Now, the group that are a problem are patients, again, who often present late, who have introital stenosis. And then they have a lot of scarring just at the fourchette. And every time they have intercourse, that tends to fissure. And we would try them, we certainly would get the lichen sclerosis as well controlled as we possibly can. We would then use sometimes topical estrogen. That is occasionally helpful. Directly on the area twice a week to increase elasticity. But those are the patients that will sometimes need specialized surgery, because the operation is a modified vaginoperineoplasty. So you bring out a small area of vaginal mucosa and remove that area, but it needs to be done in a specialized setting. Right, how often do you follow up on lichen sclerosis patients? Is it fine to let the GP follow up? Right, so what if I think maybe what we need to do is to divide them into complicated and uncomplicated patients. So patients that are complicated, i.e. differentiated VIN, atypical disease, forever. They need to be monitored by somebody that's used to looking at them. We might see them every 6 months, but they need, because they are at high risk of having a problem. But then the majority of women, if they're treated properly, will come under very good control. They will be using very little steroid. So I see them at 3 months when they've done their induction regime. Then we decide, are they going to do it once a week? Are they going to do it as needed? I would see them at 6 months. And if they say, I've needed to put my Dermavate on twice and the vulva still looks exactly the same as it did at 3 months, that's fine. But I would then still see them probably at 12 months. But women that are needing treatment maybe once or twice a week probably need to be followed up 6 monthly until, again, they come under very good control. Now, is it fine to let the GP follow up? To be honest with you, if they are really well controlled and you have a very sensible patient, they don't need to be followed up by the GP, because what they need to know is that if they get a problem, if they need to use more and more treatment, if they put their treatment on and it's not working, they need to be seen soon. We did a very interesting study some years ago where we looked at patients who had been discharged, and the patients were very good at making an appointment to see their GP once a year. But the problem is that when they saw their GP, only 17% of the patients were actually examined. So it's much more, I think, much better, because follow-up in general practice probably isn't going to work, particularly if people are not used to seeing and not used to it, managing LS. So for uncomplicated disease, it's really good patient education when they're discharged to know when they need to come back, because those patients are at much, much less risk of ever getting an SCC. And one of the things is that the development of a squamous cell carcinoma is never subtle. I think patients think they're going to miss it. They will always get a change in symptoms, something will happen, and then they need to seek advice again. So I hope that answers that question. And then, okay, so what is your opinion about laser and PRP in lichen sclerosis? I'm going to be very honest with you, and I will say that I don't think either has a role at all. We have just submitted a systematic review about the literature as it stands so far on laser and lichen sclerosis, and there is absolutely no evidence that a lot of the literature, the quality of the studies is very poor indeed. The histology is difficult, and so I would say that I don't think it has a role. PRP, yes, okay, has been used, but again, it's not really dealing with the inflammatory component of the disease, and I think we need a lot more evidence for that. Lichen sclerosis is actually quite an easy disease to treat, but the big problem is getting it right at the beginning, because patients often are told they've got it, they haven't got it, it's missed, so they do have it, but then they're told they don't have it. And so that's where it tends to go wrong. And then with the internet these days, they will often get a lot of information that isn't evidence-based, whereas when we're treating it in specialized clinics, we are treating it along evidence-based guidelines. So I think at the moment, I would say we don't have any evidence that would make me think that we should be using that. when do you think we can discharge our patients with lichen sclerosis when they're in remission? I mean, I think hopefully I might have answered that a couple of questions back. So if they are really well controlled and they know what they're doing, then that is probably fine to discharge them, but also to educate them about when they need to come back. I'm just going to go into another section a second. Maybe I'll start at the beginning. Let's just see. How long do we have to continue using corticosteroids for lichen sclerosis? Well, that can be long term. And there are some patients that will require treatment, maybe not that often, but they will require it to keep. So it is, you have to do it on the basis of an individual. You can't say, right, this is what we do for everybody, because everybody is different. And that's where clinical experience and clinical acumen comes in. So there are some that you treat them, they hardly need anything, and actually they often stop treatment and nothing comes back, and the disease does sometimes burn out. It's a minority, but that does happen. But you have to follow them up until we know that that's okay. Right. Yeah, this is an important point. So topical steroid has side effects of atrophic skin. Right. Yes, I agree with that, but there is very good evidence that if used appropriately, there is not a problem with atrophy. Again, there is a study, Annika Kai, one of my registrars, published this, that everybody worries about this atrophy, and it only ever occurs when steroids are not used correctly. So it's important to monitor the patients up, so to follow them up, make sure, but it's safe to use 30 grams in 3 months. Very, very, very few patients will require that quantity. But yes, they are safe to use if they're used appropriately and if they're put in the right place and they're not just smeared all over the thighs. So good at patient, but there isn't any evidence that you need to switch to less potent, because all that will happen if you stop using an ultra potent, the disease will just come back and then they will need to use more steroids. So don't worry. Any link between morphea and lichen sclerosis? Well, yes, there is. And there are, again, studies published that you can have a plaque on, not on the vulva, but on the extragenital skin that will have features of morphea in it and will also have features of lichen sclerosis. But so you do sometimes see extragenital morphea and lichen sclerosis on the vulva. So there is a link, but yeah. Any role of podophyllene in lichen sclerosis? I'll forgive you for saying LSA because it should be just LS. Absolutely none. There isn't any role for podophyllene. There's no role of HPV, so that's fine. When do we have to take a biopsy and to suspect squamous cell carcinoma? So basically, you only take a biopsy if there's something to see. You know, I often see patients that have been told that you have to have a biopsy now every year to pick up whether you're getting cancer. Well, that's clearly not true at all. If there is a problem where the patient's developing something, there will be something to see on the skin. So if you have atypical areas, if you have erosions like I showed you on one of the differentiated VIN slides, or you have a thickened area that isn't responding to treatment, then that's when you need to biopsy. And you need to suggest to your pathologist that this is differentiated VIN because it's a subtle histological diagnosis and sometimes it can be easily missed. Would you be so kind? So the topical steroid maintenance algorithm for lichen planus is pretty much the same as it is for lichen sclerosis, actually. Again, it's managing things, and maybe one of the things I didn't say, but with lichen sclerosis, the aim of treatment is control of symptoms and stopping progression of the scarring. What you will not get rid of is you won't get rid of the pallor. So the skin will often still look pale, but the patient has no symptoms and there is no progressive scarring. So that is the aim of treatment. Now, with lichen planus, what we would aim for is that the erosions would heal around the vestibule, but so the patient, again, symptomatically is better, but the redness, the erythema may not go, but you don't have the edge that is suggestive of an erosion. So that's that. Yeah, are the guidelines available for free? Absolutely. So if you go to www.bad.org.uk, so that's our British, or just Google British Association of Dermatologists. And if you go onto you'll find the guidelines, all the guidelines, not just for lichen sclerosis, but all the BAD published guidelines are all available for free, and you can get them easily via that website. How easily can we clinically diagnose lichen planus versus lichen sclerosis? Yeah, okay, that sometimes is difficult, but the big clues are you don't usually get erosions in lichen sclerosis, and it doesn't affect the vestibule quite as much as lichen planus does. And certainly if you've got vaginal involvement, that is going to be LP. And if you've got oral gingival involvement, that's much more likely to be erosive LP. So it is sometimes difficult if you're just going on clinical features. So it often is helpful just to do a small punch biopsy, and that will probably give you things. So, right, and there's another important point here. So how often could one apply imiquimod for persistent HPV-related VIN? Right, that's for HPV-related VIN, which is not what I've been talking about in this talk. So we would never use imiquimod for differentiated VIN. It's not HPV related. It's a completely different pathology. It's the type of VIN related to lichen sclerosis or lichen planus occasionally. So on a completely different topic, I'll answer that very quickly. I'm not going to go into it in detail, but you can use imiquimod often for, we will often use it for weeks, stroke months to treat VIN if we can see a response. But that's HPV related VIN, totally different from what we've been talking about. Right. How can we manage severe itch? I'm really sorry, that's another 2-hour lecture, because that it depends what the cause is. If it's lichen sclerosis, then manage it as we've talked. Postmenopausal pruritus, where no candidiasis or infection is found, well, again, you need to know what the diagnosis is. So if you've excluded candida and infection, is it inflammatory? Has the patient got a dermatosis? And with everything I've said, I'm a great one, I'm afraid, for making a diagnosis, not just treating, well, let's use a topical steroid if they're still itching and there's no infection. You need to really know what you're treating. Lichen simplex chronicus management. So lichen simplex is basically 3 months on a reducing regime of a potent steroid, not an ultra potent. So a potent steroid with good emollients. And lichen simplex, the vast majority of patients after 3 months, they're fine and they don't need follow-up, not any relation to lichen sclerosis at all. And then, is there any role for methotrexate in lichen sclerosis? And I guess the answer for that is I don't have any patients on systemic agents. There is a small study that shows it might be helpful, but I think it's not something. It's topical treatment by far is really what we would use. So I think that's probably we've gone through. I've not gone through all of the questions, but most of them. So I think we can probably wrap up now. But just a very brief thing is, if you do want to learn more about vulval disease, we run a anal, genital and oral disease course for 2 days, and it will be virtual this year. It's done with the St John's Derm Academy, which is the educational section of St John's where I work, and also our British Association of Dermatologists. It's in May, and again, details of where the guidelines are on BAD, British Association of Dermatologists website, and you'd be very welcome if you'd be interested. Great. Thanks.
Well, that was fantastic. And we would like to say a special thank you to Dr. Lewis for her wonderful presentation today and her superb job in answering the questions. And on behalf of the EADV, thank you for joining us. Today, we had an incredible amount of engagement by our audience. Thank you for the wonderful questions. We received so many, we didn't have nearly enough time to get through them all. Just a couple things to remind you that our next live webcast will be on April 21st on Stevens-Johnson syndrome, toxic epidermal necrolysis. In the coming weeks, also stay tuned to EADV's official podcast, The Dermatology Podcast, as there will also be a special episode on Stevens-Johnson syndrome. The Dermatology Podcast is available on all major podcast platforms, including Apple Podcasts, Spotify, and Google Podcasts. Also, we are just 1 month away from the EADV Spring Symposium. On the 6th and 7th of May, you can explore more than 30 topics across dermatology and venereology from over 100 speakers. For more information, including information about CME accreditation, go to www.eadvsymposium2021.org. Again, thank you for joining us. See you again on April 21st, and have a pleasant day.